Good afternoon. I'm Krista Lentine from St. Louis University, and on behalf of my co-authors, we appreciate the opportunity to share our work on how long is the wait worthwhile, cost effectiveness of accepting a kidney from a donor with Apolipoprotein L1 High-Risk Genotype. Support for this work includes NIH funding as part of our work in the Apollo Consortium. And this analysis is also a deliverable on the SRTR contract. And the background is that it is now well known that African ancestry is associated with increased risk of kidney disease in the general population, increased risk of kidney failure after living donation, and increased risk of transplant allograft failure. And it now appears that at least some of this racial variation is genetically mediated. Specifically, apolipoprotein L1, or ApoL1, is being recognized as a new tool for renal risk stratification in African American individuals. And in a seminal study, African American patients with 2 renal risk variants had 7 times the odds of kidney failure compared to match controls with 0 or 1 renal risk variant. In the context of transplantation, preliminary studies found associations of 2 ApoL1 renal risk variants in deceased donors with more than 3 times the risk of allograft failure. However, the clinical and cost effectiveness of use of genotyping in organ acceptance is not currently defined. The ApoL1 long-term outcomes, or Apollo study, aims to define the impact of donor renal risk variants on the survival of kidney transplants from African American donors. And pending the completion of Apollo, we conducted a preliminary cost effectiveness analysis comparing acceptance of a deceased donor kidney allograft with high-risk ApoL1 genotype versus waiting for a standard KDPI less than 85 kidney transplant. To do this, we developed discrete event simulation models with a lifetime horizon, applying a health sector perspective, and simulated 100,000 waitlisted patients aged 50 to 60 years. Distributions of time to graft failure and death were estimated from national SRTR data for standard KDPI kidney transplant outcomes. We used published evidence available to date for ApoL1 2 renal risk variant kidney transplant outcomes and for costs and utility values. Costs were evaluated at the 2020 price level with 3% annual discounting. And the findings suggest that accepting an ApoL1 high-risk kidney transplant yielded an average of 6.8 quality-adjusted life years, or QALYs, and lifetime cost of $294,000. If a standard KDPI kidney transplant were available immediately, standard KDPI transplant would yield 8.3 QALYs and lifetime cost of $382,000. Therefore, choosing a standard KDPI transplant is a preferred option at a typical willingness to pay threshold of $100,000 per QALY. However, as the waiting time for a standard KDPI kidney transplant increased, average QALYs decreased, and lifetime costs increased due to longer dialysis time and death on the waiting list. With longer waiting time, the cost per QALY gained for standard KDPI transplant increased. And when the wait time was longer than 2.7 years, an ApoL1 high-risk kidney transplant became cost-saving, yielding both higher QALYs and lower costs. Thus, preliminary analysis suggests that accepting ApoL1 high-risk kidney transplants may be cost-saving if the expected waiting time for a standard kidney is more than 3 years. And the Apollo study will enable further refinement of these estimates. So we thank you very much for your attention and interest and welcome your discussion.
a question for Dr. Lentine about, it's a broad general question. It gives you a lot of leeway to answer. What is the application/implication of this analysis to future practice?
Thank you again so much for the opportunity to share our work. So the clinical significance statement of the Apollo U01 includes a broad objective to improve the clinical and cost-effective utilization of kidneys from donors with African ancestry. And as Dr. Friedman presented yesterday in the KDPI session, replacing the race parameter in the KDPI score to generate more refined risk prediction based on APOL1 genotype is a potential application. And with rapid genotyping, testing, and reporting in time for allocation, this is anticipated to be technically feasible. So currently for deceased donor kidney transplantation, Black race is associated with a hazard ratio of about 1.2 in the KDPI score, meaning that the risk of graft failure is estimated to be 20% higher with kidneys from African American donors. Based on available retrospective evidence, the hazard ratio for graft failure associated with 2 APOL1 risk variants is estimated to be approximately 2.5 to 3. But the important point is this applies to a smaller subset of kidneys. In other words, about 15% of donors have a high-risk genotype, whereas 85% are low risk based on 0 or 1 renal risk variants. So in other words, based on refined scoring, the majority of kidneys from African ancestry donors could be scored with a lower KDPI, and this high-risk subset becomes a set of non-standard donor organs. And the question is, how should these be used? And we think the real reference is experience on dialysis while waiting. Non-standard organs produce lower utility than higher quality organs, and the care of the recipients is more costly based on a higher risk of allograft failure. But can this be balanced by survival over dialysis and cost saving from reduced dialysis time? In our pilot analysis, we compared to waiting for a standard KDPI organ among candidates aged 50 to 60 who would be good recipients for non-standard organs. And in this group, the threshold waiting time was about 3 years. More refined analysis would be tailored for candidate traits. And as Dr. Darren Stewart noted in the KDPI session yesterday, a lot is going on with regard to continuous distribution. And I believe that revision of the race parameter would be considered holistically with other potential changes, including possibly modifying how we consider hepatitis C and consideration how scoring would be used in continuous distribution. And again, thank you for the opportunity and to present on behalf of our team.